So we'll go ahead and get started with our first presenter, Alex Hirose. So Alex is a physician assistant and senior instructor in the Division of Hematology here at the University of Colorado at the Anschutz Medical Campus. Alex is a Colorado native, one of the few probably in this room, although I think Lauren sitting right next to him also is. But anyway, Alex received his bachelor's degree in integrative physiology from the University of Colorado, and then went on to get his PA at Midwestern University. Alex has practiced at several community and academic centers, including the Rocky Mountain Cancer Center here in Colorado and Georgetown University in Washington, D.C. He's been published in JADPRO and has been involved in numerous program initiatives in both the malignant and general hematology groups here at UCH. Alex is currently our co-chair of our general hematology committee. In his spare time, he enjoys spending time with his wife, his 8-month-old son, Ollie. How's Ollie this morning, Alex? And their 2 dogs. So again, really appreciate Alex bringing us a presentation on multiple myeloma this morning. Take it away, Alex.
All right. Thanks, Glenn. Can everybody hear me okay? All right. So good morning, everybody. I want to thank you for joining me to kick off our 2024 Blood Cancer Boot Camp bright and early. I'm going to be starting our presentations off with a session on pathophysiology, presentation, workup, and management of multiple myeloma. I was excited to be able to present this topic because it's something that very early in my career, this disease state is something very early in my career I found to be very interesting and accessible. To some extent, this disease feels quite a bit less abstract than some of the other hematologic malignancies can, because you see a very good causative relationship from pathophysiology to disease process all the way through to treatment. I feel like it's all very logical. So hopefully when we're done with this talk, you'll be able to see a pretty linear progression of this disease, how it develops, and what we like to do to initially manage it. So without any further delay, let's get started. Our objectives for today are to review the role of the plasma cell and discuss the immune system. We're going to be discussing when things go wrong, causing the pathophysiology that leads to multiple myeloma. We will review diagnostic criteria and the workup of multiple myeloma. There's a couple oncologic emergencies that are particularly relevant with this disease state that we'll be also going over. And then we're going to get into first-line therapy and the treatment of multiple myeloma as well. I have no relevant financial relationships to disclose, and let's get started. So we're going to be kind of working through a case study throughout the slides today, throughout this lecture. This is a real-world case study of a 79-year-old male who presented to the ER with 2 weeks of worsening back pain after a fall from a horse. Their past medical history was significant for pretty substantial cardiac issues in the past, coronary artery disease, history of an MI, and then stent placement to the LAD. They have secondary heart failure with reduced ejection fraction, and then an abdominal aortic aneurysm. In addition to this back pain caused by the fall from the horse, the patient also has associated symptoms of fatigue, constipation, and anorexia. So they get some initial labs in the ER, which show an anemia with a hemoglobin of 11. Calcium is elevated at 12.5. They also have a bit of an AKI with creatinine of 1.5. And then you can see the albumin and the PT-INR there as well. So the patient gets imaging to evaluate their back pain in the ER. And they have both plain films and CT scan done. So plain films on the right, CT scan, that's just kind of a cut of a CT scan on the left. And right away, we can see 2 abnormalities here at both T11 and L3. We have some compression fractures. The one at T11 is more substantial than the one at L3, but both of which could be causing the patient this pain. Also on this CT scan, we have a speckled appearance of the skeleton, so lots of hypolucencies within the skeleton that are diffuse throughout the entire axial skeleton. So before we move on to multiple myeloma, I want to start with a discussion of normal hematopoiesis. On this image, we have a depiction of normal hematopoiesis, and we're mainly going to be concentrating on this side over here, this right side of the common lymphoid progenitor. The left side is the common myeloid progenitor. They both derive from a multipotent progenitor cell. The left side, those cells typically do become macrophages, red blood cells, mast cells, and this development happens primarily within the bone marrow space. But on the right side, we have the lymphoid progenitor, where these cells turn into B lymphocytes, T lymphocytes, and eventually down the chain, plasma cells. These cells don't exclusively develop in the bone marrow. There is also a lot of development that happens in the secondary lymphoid organs and things like that. So we have the common lymphoid progenitor that separates into pre-B, pre-T, and NK cells that then turn into B lymphoblasts and T lymphoblasts. And eventually down, we have a B lymphocyte and we have a plasma cell. One stem cell is capable of producing 10 to the 6 mature blood cells. So there's a lot of division, and one pluripotent stem cell can really aggressively divide to make a lot of different cells down the chain. There are several different markers that we can use to differentiate these cells. For T cell markers, we have CD3 and CD4 and CD8. B cells, we have CD19 and CD20. And then NK cells, we have CD56 and CD161. So when we have a antigen or some kind of abnormal pathogen that presents to the body, it's exposed to a B lymphocyte through the presentation from antigen-presenting cells of T lymphocytes. This B lymphocyte has to have the right antibody to recognize this antigen, and when it does have the right antibody, it will clonally expand to make plasma cells. Plasma cells then secrete more antibody, which it does very rapidly. It can produce over 2,000 antibodies within 1 minute. And then those are used in multiple ways to clear the infection. When the antigen is removed, these excess B and plasma cells all die off, leaving only a few memory cells to remain. The memory cells are a small population within the bone marrow. It's less than 5% normally. And they continuously produce small amounts of antibody that confer long-term protection, and they reside primarily in secondary lymph organs. When another antigen presentation happens, they can quickly proliferate and produce short-lived plasma cells that, again, work to fight the infection. So that's what's supposed to happen. That's when things go right, as I like to say. When things do not go right or go wrong, we get a pathological fracture or pathogenic fracture, of multiple myeloma. There is no known primary cause of multiple myeloma, but as with all malignancies, there is some form of genetic breakdown or miscoding that eventually causes a breakdown of normal expansion of cells and normal clonal expansion. So in this scenario, you get abnormal clonal proliferation, and as a result, you have a large and very ineffective population of plasma cells that develop and begin to propagate. These plasma cells then produce copious amounts of immunoglobulin and non-functional antibodies that cause issues, end-stage organ damage, and problems within the body. Antibodies themselves, I want to go over very briefly to discuss kind of what makes up an antibody. So they are glycoproteins that consist of two polypeptide chains. We have a heavy chain, which on the image on the left is the Y, and then we have light chains, which are the smaller polypeptide chains, and together they form a molecule that has an antigen binding site, and they function to work for the immune system to tell what cells they need to do to clear infections. Normally, plasma cells produce a small amount of excess light chain in comparison to heavy chains, and these don't become incorporated into intact immunoglobulins. So we have what we call free light chains, or what we can see on the right-hand side. Normally, the ratio is 2:1 of kappa to lambda free light chains. Those are the two classifications of light chains we have. And they're usually not a problem. They're cleared from the blood very rapidly. The metabolism is 2 to 4 hours, and it does not take long for them to be cleared. The kidneys are what typically metabolize free light chains, and they actually have a very high capacity to do so. They can clear about 10 to 30 grams of free light chain in a 24-hour period. And the normal plasma cell production of abnormal free light chain or normal free light chain is 0.5 to 1 gram per day. So that's anywhere from a 20 to a 60-fold capacity to clear excess free light chain. So if we're having issues, then that is something that we know is a very, very high production of excess free light chain. Heavy chains are denoted by the Greek alphabet. There's several different heavy chains up here. The most important thing I want you to kind of look at in this graphic is the percentages. IgG and IgA are the largest percentages of immunoglobulins. So the majority of multiple myeloma will be IgG and IgA based on percentages. Immunoglobulins have numerous different functions, from IgM doing the primary immune response in the body, and then IgE mediates allergic reactions within the body. So allergic reactions are IgE mediated. So we have this abnormal population of plasma cells, and then we have them producing excess antibody, which is going to cause problems that we'll talk about a little bit later. They do other things that are a problem within the body as well. So they will return to the bone marrow space, and they adhere to the stroma cells, which are the cells that make up the infrastructure of your bones. And they start to break down the bones. So they do this by stimulating osteoclasts, which are the cells that do bone breakdown, and they also inhibit osteoblasts. And osteoblasts are the bone cells that build bones up. So they, throughout the body, cause lucent lesions and lytic lesions that can, lead to pathologic fractures and advanced bone breakdown. Not all patients present with an aggressive myeloma. Actually, all multiple myelomas start with an MGUS, or monoclonal gammopathy of unknown significance. This is a disease that we do not necessarily have to treat, and often we don't treat. It's classified by lab abnormalities. So you have a monoclonal protein less than 3 grams per deciliter and a plasma cell population in the bone marrow less than 10%. As these numbers increase, we progress to smoldering multiple myeloma with a M protein greater than 3 grams per deciliter, or 10 to 59% plasma cells in the bone marrow. With both of these conditions, you do not have any end organ damage, and patients are not symptomatic. When you do get end organ damage or patients develop symptoms, then you get the diagnosis of multiple myeloma. One other thing that I want to highlight on this slide that we'll be discussing a little bit later, as you can see, I've kind of put little blue marks by 6 different abnormalities in genetics that confer high-risk multiple myeloma, which we'll be discussing high-risk multiple myeloma a little bit later. But just know there's primary and secondary genetic events that allow these cells to propagate as they do. So multiple myeloma, the meat of the topic here. To diagnose multiple myeloma, you need 10% clonal plasma cells in the bone marrow or a biopsy-proven lesion or plasmacytoma. And then you also need 1 or more of CRAB or SLIM criteria. So SLIM and CRAB criteria have been around for a very long time. I think most people in the room know what CRAB criteria are. They represent end organ damage secondary to multiple myeloma. This can be C for high calcium, R for renal dysfunction, A for anemia, and B for bone problems, which we've kind of seen all of those in our case study already. And then more recently, we have SLIM criteria, or SLIM CRAB criteria, which was updated about a decade ago. SLIM CRAB criteria stands for 60% plasma cells in the bone marrow or greater, a light chain ratio greater than 100, and an involved light chain ratio greater than 100, or MRI findings of at least 1 lesion greater than 5 millimeters. So when a patient comes in and we're suspicious of multiple myeloma, what is the workup we need to do? What are the things that we need to look for? So obviously we always do a good HMP. We always do standard of care labs, but there's a few other things that we need to look into for this disease process. we're always concerned about the possibility of cardiac amyloid on initial presentation. So we get BMP, high sensitivity troponin. We also get multiple myeloma panels, such as quantitative immunoglobulins, which we'll be discussing in a second. Patients always get a bone marrow biopsy to evaluate pathology, FISH, flow, next-gen sequencing to identify the clone. Next-gen sequencing is not something that needs to be done urgently on a fresh sample of bone marrow. And in fact, our programmatic approach here at UCH is to do it by scraping slides that are archived in pathology. And then we also do a Congo stain to look for amyloid deposition. We want to get imaging, particularly if patients have bone pain or concern for bony lesions. We'll get PET CTs or skeletal surveys, and we like to get an echocardiogram, especially if we're concerned for cardiac amyloid as well, to see what the baseline heart function is. We have several different multiple myeloma panels up here. We always start with quantitative immunoglobulins, which tells us how much IgG, IgA, IgM we have, but it doesn't really differentiate between healthy and malignant cells. Then we do an SPEP and a UPEP to determine monoclonal protein and also determine if we have any kidney impairment and what amount of protein is spilling into the urine. 24-hour urine protein measures renal function in albumin that's being spilled out, and it's always done at initial time of diagnosis and is often done in clinical trials as well. The next slide here, we have two separate graphics. We have quantitative immunoglobulins and an SPEP on the left, which shows this patient had an M protein of 4.7 grams. Their total immunoglobulin is 4860. So they have an abnormal population or an abnormal lab value of IgG that's monoclonal, that's 4700, and then a total IgG of 4860. So you would think that this patient has a lot of IgG, they're not necessarily immunocompromised, but if you subtract 4700 ineffective IgGs from the 4860 total IgGs, the patient actually only has about 160 effective immunoglobulins, and they are actually quite immunocompromised. The panel on the right shows an assay that measures levels of IgG, IgA, and IgM, and the free light chains kappa and lambda. And as we can see here, there's a very strong signal for IgG and kappa free light chains there. When we do imaging, there's lots of different options. There's always lots of different options, and it's kind of hard to know what to choose sometimes. If we are not concerned and we're looking for a low-cost image just to see if there's anything going on in the skeleton, we can do a skeletal X-ray, otherwise known as a skeletal survey. But it's not that sensitive. It only detects a bone lesion after 30 to 60% of trabecular bone is lost, so it definitely can miss a lot of subtle findings. Low-dose whole-body CT is more sensitive, but we don't typically do that. We often either go to a FDG Avid PET CT or a whole-body MRI. The whole-body MRI is often done if the PET CT is denied by insurance, but we ideally like to get a PET CT if we're suspicious of smoldering or multiple myeloma in the patient. So if we go back to our case study, we'll be revisiting this patient a couple times today. They're admitted to the hospital and they undergo additional workup. They have spinal MRIs completed that are negative for a core compression, but they have an XR skeletal survey that does show diffuse demineralization and rib fractures everywhere, in addition to the compression fractures that we saw on the initial images. They get additional labs, including a beta-2 microglobulin, which is elevated. LDH is normal. They do have an M spike and elevated kappa light chains. The M spike is 1.3, kappa is 51.5, and then the ratio is also elevated. And their IgA is found to be quite elevated at 1684 as well. So when these patients come in, they're admitted typically to our service if there's a concern for a blood cancer, and we do a bone marrow biopsy. This patient's bone marrow biopsy showed clonal plasma cells at about 60%. The marrow was very hypercellular, but fortunately for the patient, there was no Congo red stain amyloid deposition. So if we think back to our slim crab criteria, the patient has hypercalcemia, that's the C. renal dysfunction, which is the R, anemia, and then bony lesions. So, you know, the C should be right there, but this would spell crab if you took it all the way down. And then they also have 60% clonal plasma cells in the marrow. So this patient was diagnosed with a IgA kappa multiple myeloma. So whenever we diagnose a cancer in general, we always like to talk about staging. Staging in multiple myeloma and in blood cancers in general is a little bit different because it is not done through how big a tumor is and where is it located. Staging for multiple myeloma is done off the ISS system, which was developed in 2005. The ISS system found that serum albumin and beta 2 microglobulin we're the most powerful and reproducible three-stage classification labs that we could find. For stage 1, you have a normal albumin and a normal beta 2 microglobulin. For stage 3, we have an elevated beta 2 microglobulin greater than or equal to 5.5. Stage 2 is kind of funny. It's just an exclusion thing. If it's not 1 or 3, it's 2. We revised the ISS in 2015 to include LDH and high-risk genetic issues like translocation 414, 1416, or deletion 17p. And then we further revised it in 2022 with the R2 ISS. This is a fairly complicated points-based system. We don't really have the time to get into this, and I think we'd all glaze over by the end of it, but this is also a new staging system that I wanted everybody to be aware of. Why does stage matter? So if we see this, look at this Kaplan-Meier curve right here, we can tell that if a patient is a lower stage, so RISS1, their overall survival is significantly better than RISS2, and then RISS2 is greater than RISS3. Again, this is the RISS, so it's off the beta 2 microglobulin, the albumin, the LDH, and high-risk genetic factors. I'm sure the R2 ISS would also, show the same thing. So we have stage, but stage isn't everything. We also need to think about risk versus stage. Risk incorporates stage into it, but there's other aspects of risk that are not necessarily related to stage. So there's cytogenetic abnormalities, which are incorporated into staging, and then laboratory factors such as LDH and beta 2 microglobulin that are incorporated into staging as well. But there's specific clinical features that would connotate a more aggressive multiple myeloma or high-risk multiple myeloma, such as plasma cell leukemia or excessive amounts of extramedullary tumor in the body. And then there's what we call functionally high-risk multiple myeloma, and this is something that we don't actually discover until after we treat the patient. So are they primary refractory, as in they don't respond to treatment initially, or do they rapidly progress within 18 months of diagnosis? We consider this functionally high risk, and we need to, be more aggressive in further treatments with these patients. This is a nice timeline graphic that I just wanted to include because it summarizes a lot of what we've been talking about. We have in the second column here, MGUS and the diagnostic criteria for MGUS, and it also notes the progression risk. It's 1% per year progressing from MGUS up, and then smoldering multiple myeloma, 10% chance of progression within the first 5 years, and then 3% progression within the next 5 years per year. And then we can see the diagnostic criteria of multiple myeloma over there on the right. As we can see with the chart on the bottom, MGUS and smoldering multiple myeloma are asymptomatic, and we don't have any of that end-stage organ damage that we were talking about earlier. Before we get into treatment of multiple myeloma, there are a couple oncologic emergencies that are particularly relevant within this disease that we do like to make sure people are aware of when we're treating these patients. The first one is hypercalcemia of malignancy. If we review our CRAB criteria, high calcium is the first CRAB criteria. So I'd like to highlight it and discuss it. It's one of several oncologic emergencies that's very common in multiple myeloma. It's a process by which elevated calcium levels cause hyperpolarization of the neuromuscular cell membrane, and that makes them refractory to stimulation, so they don't respond as they normally would. This can manifest in many different symptoms throughout the body. We have muscle weakness. We can have smooth muscle hypoactivity causing constipation. Patients can get altered or lethargic, and in worst cases can have a coma. We have cardiac effects and then kidney effects as well. Sorry. If we think about our case study, they were both had diffuse weakness and had constipation. So they had some effects of the hypercalcemia. So what do we do when we have hypercalcemia in a patient? Well, it really depends on how severe it is. For mild hypercalcemia, we see this outpatient often, and we don't necessarily have to do anything at this point in time. We can monitor and understand that we need to treat the underlying disease process, and in this case, that's the multiple myeloma. When we get moderate hypercalcemia, which is a calcium level, serum calcium level of 12 to 14, with mild symptoms, we'd like to start to think about treatment. Oftentimes, initial treatment is just gentle IV fluids, and we can give a bisphosphonate, which is a slow-acting medication that helps resorb calcium back into the bones. These take a couple days to work, bisphosphonates. So if you're looking for immediate control, it's not going to function in that way, but it does confer some long-term calcium control in these patients. For severe hypercalcemia, for patients with severe symptoms or a serum calcium greater than 14, we need to be more aggressive. You still do hydration. We still like to do bisphosphonates because they are a good long-term control of hypercalcemia, but you need to get things down in other ways. So that might be with calcitonin. If a patient is very, very ill, sometimes we have to do hemodialysis. Calcium or calcitonin is typically given IM or sub-Q. There are intranasal versions, but they don't seem to work as well. And how it works is it increases calcium excretion through the kidneys and inhibits the osteoclast activity that we were talking about in a few slides earlier. We can also use denosumab. Denosumab is a monoclonal antibody and bone-modifying agent, and the advantage to denosumab is that we can give it in renal function that's impaired. The bisphosphonates are renally dosed, and sometimes if renal function is really bad, we have to think about other options. The next oncologic emergency that is of particular interest in multiple myeloma is metastatic spinal cord compression. This is compression of the spinal column through malignancy. It causes severe unrelenting pain, radicular pain. You can have loss of neurologic function. You can have bowel and bladder issues. You can have urinary retention or bowel incontinence. These are typically late symptoms. So if you are having urinary retention, bowel issues, you need to treat this very, very soon because the process has already been going on for quite some time. If the compression is happening above L1, we call it a spinal cord compression. If it's happening below L1, we call it cauda equina. And there's 4 types. The most common is extradural, and it's the one we think about, most in multiple myeloma. It's caused by bony metastasis within the vertebral body, is 80% of the time. The posterior arch is much less likely to be affected. We have extravertebral, where the tumor originates somewhere outside of the spine and invades into the spinal column, causing compression. This is most common in lymphoma. And then we have intramedullary, which is a primary spinal cord tumor, and then intradural, where the tumor arises from within the dura. So how do we treat metastatic spinal cord compression? Steroids are the upfront management in urgent therapy. They are temporizing, but they do have anti-inflammatory and, in this talk's purposes, anti-myeloma effects, but they're not definitive. So definitive therapy is dependent on the type of tumor. We can use radiation therapy and consult our radiation oncology colleagues. Multiple myeloma and most liquid tumors are radiosensitive. There's several different things that you can do. There's stereotactic radiosurgery or external beam radiation therapy. If the tumor is not radiosensitive, you can do surgical decompression. This is often done in solid tumor. And then if you're having spinal cord or compression fractures, we can do vertebroplasty and kyphoplasty to kind of shore up those vertebrae. Another option that we don't use in this field, but it is an option, is embolism of vascular tumors, causing them to die off. The image just shows a sagittal and axial image of positive spinal cord compression findings on MRI that we took from UpToDate. So with multiple myeloma therapy, how do we treat these patients, and what do we need to think about going into treatment? So we have to think about the patient. You have to think about their performance status. How healthy are they? Are they young and fit? Are they elderly and frail? Do they want to be aggressive with treatment, or do they want to maintain quality of life? What other comorbid conditions do they have, such as our case study having pretty substantial cardiac issues? And then do they have the support to get to and from appointments weekly, supportive care, et cetera? We talked about staging. We need to think about high-risk disease, high-stage disease, whether or not there are oncologic emergencies actively happening. And then where are they going to be? Are they in the hospital, or was this diagnosed in the community and then they were referred, and we're taking this at a I don't want to say casual, but less urgent pace than we would be if a patient came in pretty aggressively from the emergency department. We have several classes of drugs, and it's an ever-growing list of drugs that we can give to treat multiple myeloma. I'm not going to be going into several of these because they're going to be addressed this afternoon, but we are going to talk about some of our initial therapies and our initial regimens for multiple myeloma. First off, we'll start with steroids. Steroids are a mainstay of multiple myeloma therapy, and they're present in nearly all regimens. The only way they'd be excluded is if a patient was not tolerating them, or if they were on some kind of maintenance therapy like a low-dose Revlimid or something along those lines. They have numerous anti-inflammatory and anti-myeloma effects, but they also have lots of side effects, as we know. Long-term steroids are not kind on the body. They can cause immunocompromise. One thing I didn't put up here is GI side effects. We have to worry about peptic ulcer disease and have to put patients on a prophylactic PPI. There's also psychological effects. Patients talk about insomnia or hyperactivity or mood swings. And then if a patient has diabetes at baseline, we run into a lot of issues managing the diabetes with the high-dose steroids that are in regimens. Alkylators are traditional chemotherapy medications, and they function as traditional chemotherapy medications would. They do not discriminate, and they just take out any highly proliferative cell in the body. This causes a lot of issues, and they also have a lot of side effects. Cytopenias across the board, mucositis, other GI side effects such as nausea, vomiting, and then there is a chance later on down the line that they might cause a secondary or a second primary malignancy. We'll get into that a little bit later when we talk about auto transplant, but alkylators are pretty rough. We do high-dose melphalan, we'll do cyclophosphamide, but they can cause a lot of side effects and a lot of comorbid conditions for the patients. Proteasome inhibitors have been around for a while. Bortezomib was the first one. It came out in 2003. Basically, how they work is they block cellular cleanup within cells. They build up with toxic proteins and eventually die. They have some class concerns that we need to be aware of. All patients need to be on continuous antiviral prophylaxis to prevent shingles. Bortezomib is well known to cause peripheral neuropathy, which is something that can cause dose reductions or tolerance issues with our patients, especially if they have baseline peripheral neuropathy, say from diabetes. And then carfilzomib, we have to be pretty cautious dosing, especially patients who have cardiac issues. We have to put them on VTE prophylaxis. And then we also, before we start, most of the time we like to get an echocardiogram. Sometimes we'll give a cycle and then get the echocardiogram if we're really trying to get a patient started. But we do need to be aware of cardiac function with carfilzomib. We also have IMiDs as a class. IMiDs have been around for a very long time, particularly thalidomide. We all know about the embryo-fetal toxicity issues with thalidomide, so we have a REMS monitoring program for these drugs. The biggest thing that we need to be aware of with IMiDs is the chance for clots or venous thromboembolism. It's a well-known concern, and we have patients on VTE prophylaxis as soon as they start an IMiD. The other thing we need to worry about, particularly with full dosing of these drugs, is cytopenias, and we will occasionally have to dose reduce the lenalidomide if a patient's on like DVRD or something like that. And patients, if they have prolonged neutropenia, we do put them on prophylaxis for bacteria. Monoclonal antibodies, it seems like you can't turn on the TV without seeing a new advertisement for a new monoclonal antibody, but they are relevant and very helpful in multiple myeloma. Daratumumab, I remember when it came out, everybody was very surprised by the unique sinus effect of daratumumab on initial infusion, but now that we know how to manage that, it's very helpful and it's a great tool for fighting multiple myeloma. Monoclonal antibodies work in a varying assortment of ways. You know, they either cause antibody cell death or complement cell death, or they stimulate macrophages to come in and eat up the plasma cells. The biggest things that we need to worry about with most monoclonal antibodies are hypersensitivity reactions. They can be fairly substantial. And then the other thing about daratumumab is it can interfere with SPEP interpretation. So that's something else that we need to keep in mind when we're evaluating patients' labs and response and things like that. So here we just have the NCCN guidelines, and I'm going to be highlighting two separate regimens that we like to use here. There's a primary delineation between auto-eligible and auto-ineligible patients, but typically, just to know, non-transplant candidates are sicker, they have more comorbid conditions, they are older or more frail, then that might prevent them from receiving an auto transplant. At our institution, we typically like to do DVRD or daratumumab, bortezomib, lenalidomide, and dex. We prefer to start with a 4-drug regimen for both transplant eligible and transplant ineligible patients. If we're doing a 3-drug regimen, we are removing the bortezomib, and sometimes we might do that for, you know, long-standing peripheral neuropathy issues or something like that. But we really prefer to do 4 drugs. If we can't do 4 drugs, there could be certain reasons such as age, comorbid conditions, patient's desired quality of life that will affect what we choose, but we'll generally lean towards the 4-drug regimen. One other regimen that I want to discuss briefly is CyBor-D. CyBor-D is bortezomib, cyclophosphamide, and dexamethasone. So daratumumab is often not readily available immediately for inpatient administration without some delays in patients who are presenting through the ER with really bad disease that has been left untreated for a long period of time. So given the very acute nature of initial myeloma presentations, at times we will induce with a cycle of CyBor-D inside the hospital to get initial disease control and at least to get the patient temporized and stable before discharging further treatment outpatient with DARA-containing regimens. It's important to note that, you know, CyBor-D is probably not going to be around for that much longer. Things are changing so rapidly, and we are just getting better and better drugs that we might not have to deal with this soon. But it is something that we will occasionally do depending on what the situation is with the initial presentation of the patient. As I said, this landscape is rapidly evolving. I included this slide just to show all of the different trials that in upfront therapy of multiple myeloma that are going on or have recently been completed. The only one I'm going to highlight is the Griffin trial, which added daratumumab to VRD, which is our programmatic preference here. When we added daratumumab to VRD, patients obtained a very good partial response in 72% of the time versus 57% of the time, so a pretty big jump. And then MRD negativity was obtained in 21% of patients versus 6% of patients. So, you know, this really is just said to highlight how quickly and how substantially the landscape in initial therapy is changing. Briefly, we'll go over minimal residual disease. MRD status and MRD negativity are becoming more and more important, and some of the best tools to predict outcome in multiple myeloma patients. Tumor markers are only capable of detecting disease above the immunofixation line on the right graphic. So MRD is having a more prevalent presence in evaluating how well patients are responding to disease. In spite of this, it's still not routinely done in a lot of practices, but it's something that we see as a more and more important piece of the puzzle. How do we determine how well patients are responding to multiple myeloma? So the International Myeloma Working Group came up with widely accepted response criteria to treatment. This slide, it's progressive disease, stable disease, and minimal response. We don't really use minimal response all that much, and we don't have time to get into the weeds of kind of the progressive disease. But what I really wanted to talk about here were these. So this is how we determine how well a patient is responding to therapy or how well we classify it. We have partial response, which is a decrease in both serum and urinary M protein and a decrease in the size of plasmacytomas. We have very good partial response, where our M-star spike is no longer detectable on electrophoresis, but we can still see it in immunofixation. Or we see a greater than or equal to 90% reduction in serum M protein and a urine M protein less than 100. A complete response is a negative immunofixation M spike and no detectable plasmacytomas, and plasma cells in the bone marrow are normalized less than 5%. And then there's stringent complete response, which is the same as complete response, but the free light chains have also normalized and we don't have a clonal population detected. So obviously we're going for as deep as possible, but we don't always get patients there. Before we get into kind of our closing of our case study, I wanted to touch briefly on auto transplant. So auto transplant has long been a staple of multiple myeloma therapy. We historically have collected patients when they're in remission, and they would go to transplant after approximately 6 cycles of therapy. This is not as routinely done now. We still routinely collect after they get into their first remission, but we sometimes just store the cells for later use. The way a transplant works is we give a high-dose melphalan, conditioning chemotherapy, and perform a stem cell rescue with their previously collected cells. But this process is not without significant comorbidities as well. There are potentially severe and life-threatening infections that can develop. Patients can get substantial GI toxicities, mucositis, nausea, vomiting, diarrhea, and they also have a significant interruption to their normal daily life for weeks to months. And then another big concern we have from the conditioning chemotherapy is the risk of potential secondary cancers or second prime malignancies following conditioning chemotherapy. And we do see this sometimes. We treat patient for multiple myeloma for a very long time, and then they develop an MDS later on in life. So it has still been shown in recent studies to be effective when compared to some of our older chemotherapy regimens. But with all the new things coming out, all the new studies happening to see what the best upfront therapy is, it's not really clear how relevant auto transplant is going to be in the future. Compared to when I started, over a decade ago, we're doing a lot less auto transplants, and we're doing them a lot less aggressively or a lot less upfront than we used to. It still plays a role and will probably still continue to play a role, but what that role is exactly, we're not quite sure. So in closing, we'll get back to our case study. Our patient was diagnosed with ISS2, RISS2 IgA capable multiple myeloma, and they received induction therapy for DRD. And if we remember, they had significant cardiac complications. They were pretty frail. They were pretty elderly. So we did not give DVRD. We gave DRD. In addition, they received T11 and L3 kyphoplasties for those compression fractures, and they achieved a partial response because we got their M protein below 50%, but it was still detectable. And then, we, with this patient, I believe, continued with a maintenance therapy for some time. This afternoon, my colleague Kelly Sider will be discussing the new and exciting novel therapies that we have for multiple myeloma, but this is where my discussion ends. So I want to thank everybody for listening and kicking things off. Hi, Sarah.
Hi, can you hear me?
Yeah, kind of.
Does anybody have any questions?
Thanks, Alex. That was an amazing talk.
Thanks.
I was just curious, how long in your experience do you kind of see patients continue on this maintenance therapy, and what does that look like? Like, do they continue with that same quad regimen or potentially 3-drug regimen? And for how long can that go on?
Yeah, so we have patients continue on for a very long time. I mean, we'll have patients, I think we have someone on their 104th cycle of daratumumab, maintenance daratumumab. So we have patients on maintenance therapy for a very, very long time. The frequency of treatments decreases from weekly to biweekly to monthly, and then they eventually just go on a monthly treatment. It is very patient specific, and it's not necessarily how we see it delineated in the NCCN guidelines, for example. But we will have patients who are even on bi-monthly or every 3-month treatments and things like that in our practice. And it's just because that's what they prefer and they want to go on their trips. And they don't want to have to come into the hospital once a month. So it is variable quite a bit, but it's a decreasing frequency and typically decreasing, number of drugs as we move on. So.
Any other questions?
Thanks, Alex. That was a great talk. I think, like you mentioned, we're going to go into some of the new and cool therapies of multiple myeloma this afternoon with Kelly. But, without really kind of understanding how to diagnose a myeloma patient, how to understand the complications, how to treat and manage the complications, and, get them to their first round of therapy, it doesn't matter, if you have a lot of fancy new drugs to use on them. So I really appreciate kind of the basic management of these patients. Very important. One quick thing that I just wanted to ask, and I know we need to get going with Lauren's talk, but these patients in regard to their immune paresis, they're overproducing all these inadequate immunoglobulins. And can you just talk just briefly about kind of our approach to managing and basically preventing infectious or opportunistic infections in multiple myeloma patients?
Yeah, so it does depend on the patient and what kind of cytopenias and other issues we're having. All of our patients typically are on antiviral prophylaxis, though, to prevent shingles, opportunistic infections. Further prophylaxis really does depend on the patient, the attending sometimes, and how low their cytopenias are becoming. We have a lot of issues with Revlimid-induced cytopenias, and Revlimid can really knock down the neutrophil count. And in those patients, we will do intermittent dosing of prophylactic antibiotics. If they're on long-term steroids, they have to be on PCP prophylaxis. So it is patient-specific, but we typically use at least one and sometimes all of the prophylaxis avenues at our disposal to kind of prevent opportunistic infections as well. And then ideally, as we treat the disease from its initial presentation, the likelihood you're going to get most opportunistic infections are low. As the bone marrow starts functioning more normally, hopefully the neutrophil count will improve and stay more stable, and we won't have to aggressively reduce the lenalidomide dosing and things like that.
Thank you very much.